Here, just a little bit more information about anxiety disorders. What's the developmental course? Well, there's a variety of diverse outcomes, of course, because we're talking about so many different disorders and attempting to cluster them together. But there is overwhelming strong evidence for continuity into adulthood for most children who do get a diagnosis of an anxiety disorder. It's comorbid. There's high comorbidity with other anxiety disorders, right? Also with depression and substance abuse disorders. Girls are more likely to have 2 or more anxiety disorders, and girls are more likely to have anxiety and depression. So we do typically think of anxiety disorders as more prevalent among females, and they're at greater risk. A few other aspects of etiology here. Heritability is high at 30 to 40%, depending on the disorder. There is genetic overlap that is seen between anxiety disorders and mood disorders. That's why it's not surprising that we see depression up here in a comorbid list. There are abnormalities involving the amygdala, which is the part of the brain that is involved in emotion regulation, not surprisingly then. Neurotransmitter dysfunctions, dysfunctions in the autonomic nervous system. Remember, that's where fight or flight is originating. Also within the child, differences in child temperament. So the children who are at greatest risk for developing anxiety disorders in terms of their temperamental profile, they are very inhibited children. So that might mean that they're very wary. It could mean shy. They're also highly reactive. And they also will be children who have poor emotion regulation. So children who lack skills to regulate those frequent negative emotions that they experience, such as fear. So children with poor emotion regulation observed in childhood are at an increased risk of developing an anxiety disorder. Also children who have certain cognitive or attentional biases or distortions. So in other words, things are magnified. Things that some children might say, oh, I'm a little bit nervous about that, but it's not a big deal or it probably won't happen. Children who have an intentional bias where they tend to really focus in on and notice threatening or harmful situations, right? They get magnified for them. So that's the distortion element of cognition. And the intentional element is that they just tend to notice and perceive things that could be potentially threatening more than other children. There are also children who have greater anxiety sensitivity. They tend to focus on and overreact to certain uncomfortable body situations, things like stomach aches or just feeling uncomfortable in their own skin or in their clothes. And so they notice them more and they tend to react negatively. And that's anxiety sensitivity. And a few more bits about the etiology of anxiety disorders here, sort of moving beyond things like physiology and getting a little bit more environmental. So we learn anxiety, think of learning theory and modeling. So if a parent is modeling sort of highly neurotic behavior and a lot of anxiety, then we are exposing the children to that as well. Also think about classical conditioning and operant conditioning. You could imagine that certain fears could be conditioned based on experience or environmental events. Children who have insecure attachments to their caregivers are at an increased risk of developing anxiety disorder, and children who have experienced adverse life events, loss in their life, parental divorce, abuse, problems with peers, problems in school. Think of diathesis stress here, right? We've talked about that high genetic or high heritability rate, and then you insert an adverse life event. We've got our diathesis stress that we've talked about a lot already. Other family context or parental factors, parental psychopathology, right? So if you have a parent with psychopathology, that's an increased risk factor for an anxiety disorder. And then there are certain qualities of parenting styles that tend to be linked to a greater risk of developing an anxiety disorder in childhood, particularly parents who are over-controlling and overprotective, also parents who are intrusive, and also parents who are negative and critical. All of those parenting styles are associated with a greater risk of anxiety disorders in children. The most concerning is the overprotective, over-controlling parent. Okay, because you can imagine that the children don't feel like they can do things on their own and they're worried about things happening. And they're kind of drawing that conclusion from the amount of overprotection and over-control that the parents are providing. There's some research specific to fathers. Fathers who exert very high control and show a lack of affection. That particular fathering style seems to be linked to anxiety disorders in children. And one little caveat is we want to remember cultural context. So if you've studied parenting styles before, you know from other classes perhaps that in some communities, controlling parenting is more common and it's just part of the culture. We tend to see that in urban and low-income environments and certain ethnic cultures. And so where that's a more normal part of the cultural value and cultural context, then we don't see as strong of a correlation between that controlling parenting and the anxiety disorder outcome. Okay, and finally, just want to introduce obsessive compulsive disorder. It is within a separate class of disorders in the DSM. It's known as a disorder of ritual and doubt. It's marked by obsessions and compulsions. So obsessions are thoughts, persistent and intense intrusions of unwanted thoughts or images. Some of the most common for kids: germs, contamination, harm, death. Compulsions, I have a soap dispenser here and hands for hand washing. Compulsions are behaviors. These are persistent and intense impulses to perform a specific behavior. Some of the most common are checking things, double checking, arranging, rearranging things, putting things in a certain order, counting things, hand washing, praying, repeating things in your mind over and over again. So the obsessions and compulsions are very time consuming. At least 1 hour per day is spent devoted to them. The prevalence in kids is somewhere between 1 and 2.5%. Males are more commonly affected in childhood, and females are slightly more commonly affected in adulthood. So we are more likely to see OCD in boys in childhood. 25% of cases of OCD start by age 14, and some other related disorders that are in the same cluster in the DSM-5 we've spoken about in class a bit: trichotillomania or hair pulling, body dysmorphic disorder, hoarding disorder, and excoriation or that skin picking. Thanks, guys.